Hello, I'm Nancy Kentish-Barnes. I'm a sociologist and I work in Paris for the French research group called Familia. We will be discussing human factors and crisis management and more precisely what research can teach us about this topic. I'd like to begin by introducing myself and tell you what I hope to bring to you through this presentation. As I said, I'm a sociologist and what I do is research. So contrary to, let's say, a clinical psychologist, I do not intervene in the field. I observe, interview, question and analyze what I see and hear. And then obviously with my colleagues, we hope to propose strategies to improve people's experience. So at the beginning of the epidemic, our research group received funding from the French Ministry of Health for a national research project that aimed to better understand the experience of ICU patients and families during the crisis, as well as the experience of ICU clinicians, using both a qualitative approach with interviews and a quantitative approach with a survey. So the idea is to see what these studies teach us about clinicians' experience during the crisis, what are their needs, and how can we improve their experience. We're talking about human factors, so we're talking about how humans behave physically and psychologically and how they interact in relation to particular environments. As you know, much of healthcare is dependent on the humans, the doctors and the nurses who provide the care. So it is important to study the factors that will make it easier for them and for you to do the job in the right way, and to help design processes that will make it easier for you to do the job right. Now, during the crisis, there were many different social and psychological aspects that could be studied, including the way individuals make sense of the crisis, the way cognitive processes influence individuals, role ambiguity, communication, the role of emotions, the skills needed for crisis leadership, and psychological burden and coping strategies. Of course, I can't address all these points, and I will concentrate on some only. So after a brief introduction, we will discuss the contributions of qualitative research, particularly the lived experience of ICU clinicians during the crisis, and see what strategies can be developed to improve their experience and your experience. And then we will discuss quantitative approaches and more precisely psychological burden experience during the crisis and what preventative strategies can be developed. So first, I would just like to say that during the COVID crisis, our social life was basically turned upside down with general lockdown, social distancing, daily death counts, which were extremely stressful, infodemic, which is, as you know, an excessive amount of information that is typically unreliable and spreads very rapidly, economic uncertainty, etc. The list is long. In the hospital environment, as you know, hospital policies were modified, care was reorganized, intensive care capacities were extended with additional staff and new wards that were created, and healthcare professionals were sometimes asked to change their roles and to play less familiar roles, which can sometimes be quite unsettling. So all this to say that the epidemic had a strong impact on all citizens and did generate a lot of stress. And of course, ICU clinicians are on the front line, and they were being asked to provide care in a context of high risk, high uncertainty, and in conditions that were running against over 20 years of recommendations aiming to improve patient and family-centered care. So in this context, obviously, it was possible that these clinicians experienced trauma being a deeply distressing or disturbing experience. And this is what we will see now. So first, what does the qualitative approach teach us about the lived experience of ICU clinicians during the crisis? In our qualitative study with interviews, our results showed that the first experience was one of initial disorganization, the feeling of being totally overwhelmed during the first few days or the first week of the crisis. Terms used such as confusion, madness, oppressive, shock, brutal, being on Mars, etc. were used in many of our interviews. But what participants did say was that having rapid guidelines and protocols as well as clear communication did help them find their bearings. So dynamic prioritization is extremely important. As this nurse says in one of the interviews, thank God they got their act together quickly. It took about a week, but after that instructions were clear. We knew what we had to do and how. We adapted. It wasn't easy, but we felt we knew where we were going. We weren't like in the dark, like we were at first. Fear is also very strong. The fear, obviously, of being contaminated in case of lack or faulty personal protective equipment, but it was interesting to see that fear was less strong in the work environment and that clinicians were more fearful of being contaminated on public transport, in the supermarket, and that the hospital actually felt like quite a safe place, quite. And the fear, obviously, of contaminating loved ones was important, and some clinicians chose to live at a distance during the epidemic, which isn't easy, and some did try social distancing in the home at the beginning, but this also was quite complicated. As this nurse describes, one night I woke up, I was sweating and I thought I had a fever, and in fact I was really stressed out. That's when I realized that I was actually really afraid of being infected, and so I panicked. I had a hard time breathing and I thought, well, that's it, I've got a severe form, I'm going to have to be intubated. I think this quote is important because it shows how strong the fear can be, and it can be psychological but also physical here. And this nurse, in fact, wasn't ill at all. She didn't even have a cold, but she was just experiencing intense fear. And all participants did say that this fear was extremely burdensome. Now, it is interesting, and this qualitative study from China just confirmed this, that negative emotions are extremely strong at the beginning of the epidemic, and slowly as clinicians find their bearings and start to give meaning to their role and their activities, more positive emotions do emerge and start to coexist with the negative emotions, meaning that although it is difficult, the experience is not only negative. I think this is important to bear in mind. Our study also showed that there was an intensification of professional relationships. First, the quality of professional relationships and the importance of teamwork. I realized that we were a tightly knit team and that we listened to each other a lot. Without that, I don't think we could cope. Collaborating with colleagues outside the ICU and the importance of solidarity. Everyone is participating in their own way and as best they can. And it's quite amazing to see the collaboration we have with colleagues we don't even know. And last, enrolling non-expert ICU clinicians, which does create a strong sense of cohesion. We really felt supported. We had new nurses coming and who were really willing, really committed. It was such a help to have them. So what is important here is to build team resilience. I think that if you are in this situation, it is important to communicate and to talk about how you're feeling and what's going on. It is important that you have access to information that is clear. It is important also that you focus on what you can control. In a context of uncertainty, you can't control everything, but if you focus on what you can control, then it will make you feel stronger. It is important that you maintain positivity and to make sure that you can ask for help when you need it. Now, for clinicians that were new to the ICU, in our study, they did say that it was sometimes difficult to find their place, that they were discovering obviously a new world, a new team, and many of them that we interviewed did stress the importance of ICU atmosphere, that this atmosphere meant that they felt welcomed and wanted. This was important. They did also insist on the importance of leaders who were able to give them clear instructions and a clear role. It was difficult at first, says this nurse, because I really couldn't cope on my own. I needed the experienced nurses to guide me through most things, and sometimes I felt I wasn't really a great help. But the team is great, and now I am more independent and I can do things on my own and can sometimes show some initiative. This is a really important quote because being able to show initiative is fundamental in a team, and I will mention this a little later on in my presentation. In the second quote, I felt overwhelmed at first. There were so many things to remember, and feeling stressed made things more difficult, I think. I was constantly afraid of making a mistake. I needed things to be clear. I think this is also a very important quote, this person saying that they were stressed about making mistakes and they needed things to be clear. Once again, I will discuss this later on in my presentation. All clinicians, whether experienced or less experienced, were working in unusual working conditions, obviously with the unique features of these COVID patients who presented a lot of uncertainty, and not being in control is very unsettling for ICU clinicians, and also caring for patients who all have the same clinical features creates a sense of monotony, and we know that monotony can have a negative impact on job satisfaction, and it may also be associated with an increased risk of making mistakes. So this is an important aspect of clinicians' experience that must be taken into account. It's getting a little robotic. I find that we have lost the relationship with the patient. Even our transmissions are less precise and we don't discuss little details as much. I think that as it's the same for all the patients, we just spend much less time talking about them. So there is a risk here that you must bear in mind. And also during the crisis, clinicians were working under new constraints concerning family members. As you know, there was an initial ban on family visits, and this did create a lot of frustration. But this frustration, and this is interesting, could also generate interesting initiatives. For some patients, says this nurse, we organised video calls, even if the patient is intubated, but at least the family can see the room and see what's going on, because just explaining with words is very difficult. And in end-of-life situations, clinicians did find that discussing end-of-life decisions with families at a distance was more complicated, and the loneliness of dying was extremely difficult for clinicians, especially nurses, who felt a strong responsibility of having to be there and hold the patient's hand as he was or she was alone. So what strategies should be discussed when taking into account all these quotes that I've just discussed with you? Well, of course, in a rapidly changing context, it is important that you avoid reliance on memory. There are so many things you've got to remember that it's difficult to rely only on your memory. So it is important that ICUs use pictures or diagrams of steps involved in a procedure to make it easier for you. And also the ICU must make things visible for you using pictorial reminders, and all cognitive aids are helpful. It is important also to simplify processes, as we know that simple is better, and to implement communication strategies that are fewer in number and clear in purpose. I think this is important. And at a hospital level, if possible, to standardize common processes for clinicians who may have to move from one ward to the other. Another important strategy to develop is appropriate leadership, but just first I would like to provide here a short reminder. What makes leadership happen? It's a phenomenon that emerges from a relationship between a person on one side and others, the team, colleagues, partners, etc. And leadership doesn't only manifest itself in a person because of their innate or acquired qualities, but also through the relationship that is established between them and those on whom they have an impact, without forgetting the role that these followers or you play in the relationship. So I just wanted to insist on the importance of the relationship. And as strategies go, obviously it is important to develop appropriate leadership. This means that leaders must provide support that is both tangible and intangible. Obviously PPE, but also making sure you have access to childcare, to mental health services, etc. The idea is that they must make you feel safe when you're providing care to the patients. And of course, communication is important, clear and factual communication, avoiding over-normalizing or over-catastrophizing communication. As you know, a balanced leader who doesn't go from one extreme to another, but who remains consistent in the way he or she communicates, is extremely reassuring for clinicians, and also avoiding role ambiguity. So to sum up, I think we've seen how important workplace culture is, and this must be obviously a safety culture, both for the patients, but also for clinicians who must feel safe both on a personal level and on a professional level when they are working. And also a culture that recognizes and values all clinicians and what you bring, whether you are experienced or not. And the importance of leadership, I've already mentioned this, but it is important that leaders prepare you for your roles and prepare you with communicative skills. And it is important also to remember that effective organizations have leaders and followers with overlapping values and qualities. Now, you might know this picture from the business world, but what we're not looking for a boss who stands above and who gives orders. We're talking about a leader who shares your objectives, who shares your values, and who's there on the field with you, rolling up their sleeves and inspiring you and also listening to you. I think this is really important. Third point is the importance of teamwork, and these teams can be quite complex during a crisis with many new clinicians, and it is important to remember that how you view your role really does affect the quality of your work and your interpersonal interactions. And also it is important to develop peer support and team resilience. And the importance of followership. We've said how important leadership is, but followership is also important, and it's the ability to recognize the shared purpose and interdependence of team members, to think independently and critically. It's not just obeying orders, and to show courage and a supportive team-orientated attitude when challenging leadership decisions or plans. To give you an example, in one of the ICUs I studied during the crisis, after the initial ban on family visits, a group of nurses challenged this decision using obviously well-constructed arguments, taking into account the team as a whole, communicating without aggression, and the leaders did listen to them and took their arguments seriously, and this resulted in a change of policy and the possibility of family visits in certain conditions, obviously. So just to say that followers can have many interesting initiatives and also power to change certain practices. Now, the second part of my presentation is what quantitative approaches can teach us about psychological burden in clinicians caring for COVID patients during the crisis in the ICU. I'd like to start with this first study coming from China, which is a survey including over 1,200 clinicians, 61% of nurses, 40% nearly of physicians. And this study showed that symptoms of depression were extremely high in over 50% of clinicians, symptoms of anxiety in 44% of clinicians, insomnia, and a lot of distress, as you can see, in over 70% of clinicians. The study showed that there were more severe symptoms in nurses, in women clinicians, and in frontline clinicians who were in direct care of COVID-19 patients. So it is important that clinicians' well-being becomes a priority. It definitely needs attention, because one can't expect you to do your job right if you are feeling distressed, anxious, exhausted, etc. And this other study, which is a survey from our research group in France, which was done in 21 ICUs and included over 1,000 clinicians. And we also showed that there was a lot of anxiety in 50% of clinicians, symptoms of depression in 30% of clinicians, and peritraumatic dissociation in 32% of clinicians. And their highest rates were found in nursing staff. As you can see here in this table, nurses and nursing assistants had higher symptoms, anxiety, depression, and peritraumatic dissociation. In our study, we found that factors associated with increased risk of anxiety were being a woman, being a nursing assistant, the fear of being infected or contaminated, regrets about restricted visiting policies for families, and the inability to rest. Factors associated with increased risk of depression were being a woman, the fear of being contaminated, the fear of contaminating colleagues, witnessing hasty end-of-life decisions, regrets about restricted visiting policies, and the inability to rest. And the factors associated with increased risk of peritraumatic dissociation were being a woman, being a nursing assistant and a medical student, fear of being infected, witnessing hasty end-of-life decisions, struggling with emotions, inability to rest, and inability to care for family members. So what you see here is that in red are two factors that are associated with all three symptoms, the fear of being contaminated and the inability to rest, but there are other factors that are shared by two symptoms, such as the regrets about restricted visiting policies or hasty end-of-life decisions. So I think it is important that you focus on your fear. We know that fear causes fatigue, discomfort, feeling of helplessness, the inability also to use self-coping strategies. It fuels frustration and isolation, and it does impair your decision-making capacities. So it is important to work on this fear. It is important also to focus on your inability to rest, as we know that this inability to rest can generate impaired neurobehavioral performance, and we know that insomnia raises concern about patient safety. So it is important that you preserve your sleep quantity and quality. Now, the ICU is responsible to develop strategies to decrease psychological burden, and decreasing psychological burden will not only improve, obviously, healthcare professionals' well-being, but will also improve patient care and the ICU atmosphere. So they must focus on clear communication, access to adequate PPE, adequate rest and psychological support. And leaders in hospitals and in ICUs are responsible to develop strategies to prevent this psychological burden. They must develop work schedules that ensure rest time and time at home, opportunities for short breaks. Ethical decision-making and end-of-life care is important. There must be continuity in the sequence and in the timing of decision-making processes between the pre-epidemic period and the epidemic period. And also, it is important to discuss visiting policies. And also, you're also responsible of finding ways to decrease psychological burden and developing self-care. I think this is fundamental, and it's just small things that are important, like learning to disconnect from work, regular sleep, food and exercise, cultivating a sense of self-compassion, having interactions outside the work environment that aren't COVID-focused, only COVID-focused. A lot of clinicians say that their whole life became COVID during the epidemic, and also seeking help when needed. So when we're talking about human factors and crisis management, I think it is important to bear in mind an ABCDE figure, A being awareness of possible trauma, anticipation, and attention to clinicians' well-being. B for building a strong team, building team resilience, and building clinician self-care. C for communication, for cognitive aids, and also for being able to call for help. D for dynamic prioritization, decision-making, and distribution of roles and workload. And last, E for evaluation, and environment, working on the atmosphere, organisation, visiting policies, etc. So I think that when you have been through such an experience, it is important to be able to debrief either at a hospital level or ICU level, the idea being to discuss points of strength and points of weakness. So what we've seen, well, I hope that we've seen throughout this presentation, is that during the crisis, there were many negative emotions, negative feelings at the beginning of the crisis that can then coexist with more positive feelings, but that can also generate psychological burden. I think that what we've seen is what helped clinicians do the job during the initial crisis was clear information, dynamic prioritization, adapted leadership, and teamwork. But I also think that what we've seen is that there were some things that were missing that were self-care, adapted decision-making, attention to trauma, and attention to the environment. So I think it is important to keep on working on these aspects that were already developed during the first epidemic, and also to develop more attention to self-care, decision-making, ethical decision-making, trauma, and environment. Finish with a more positive note with this quote. I have learned so much from the crisis. I feel stronger. I know where my priorities stand. This is why I became a nurse, to help patients and to do work with a team. And that's what I'm doing now. And I know this might sound surprising, but it feels good. So I think that this shows that if human factors are anticipated and addressed correctly, then during a crisis you can learn a lot about yourself and your work, and you can make it a stimulating experience. Thank you.